It is your presence here today that reinforces my belief that in spite of anything we may read or hear about the problems that face healthcare in our country, the two most important reasons for becoming involved in medicine and nursing really has never changed with the passage of time. It remains as old as the institution itself. Number one, an abiding fascination with science and technology for sure. But even more important than that, deep down inside all of us, it's a burning desire to help those in need of care. To me, there is no greater opportunity, responsibility, or calling than to be a physician, a healer. The evolution of medicine and nursing has compelled all of us to become much more introspective about our profession, our community, and our goals. For many of us, there is faith in science and technological advances. But I'll let you in on a little secret. In my humble opinion, the role of technology, although wonderful, can be emphasized far too much. For in spite of the dazzling new advances that have come along in recent years, nothing is as wonderful as the human heart, the human mind, and the human spirit, when it is put to use in the service and the care of others. After all, medicine and nursing are serving professions. They exist not for their own sake, but for the benefit and the care of others. Your presence here on a Saturday afternoon speaks clearly to your dedication and commitment. And for that, I applaud and salute each and every one of you. My talk this afternoon is entitled Cardiac Pearls, or more affectionately, as the new edition of Clinical Cardiology Made Ridiculously Simple says, where's the love dove? Because when we think and reflect on where we are in medicine in general, and in cardiology in particular, in the year 2022, I can't believe it's 2022, we are truly, in my mind, at a crossroads. On one extreme, we live in this era of high-tech medicine, don't we? We have CT scans, PET scans, cardiac MRI, echocardiograms, nuclear images, angiograms. Wow, great stuff. There's only one problem. We can't afford all of it. We also live in an era on the other extreme of cost containment, managed care. At no time in the history, therefore, in medicine and nursing, has the need been greater than it is today for all of us to recognize the importance and the growing need of the talents and the skills of a well-trained clinician. So what is a clinician? A clinician is a person who can use their own senses, the sense of sight, inspection, of touch, palpation, the so-called laying on of hands, and listening, auscultation, with the aid of a simple, musical, if you will, instrument called the stethoscope, to make rapid, accurate, cost-effective diagnoses each and every day at the bedside, in the hospital setting, or in the office or the clinic, without having to be so over-reliant, over-dependent, beholden to all of the elaborate and expensive laboratory tests that have become available to us in our modern hospitals, literally at the push of a button. Now, don't get me wrong. There's no question that technology is wonderful. It is. And that modern scientific advances have propelled us into the forefront of the diagnosis and treatment of not just heart disease, but all diseases. But at a time when we're thinking about the rising cost of healthcare and avoiding potential harm of a test that may be risky, that may or may not even be necessary for a given patient, it becomes even more important for all of us to understand what a well-trained clinician can do with his or her own eyes, hands, ears, and brain when he or she evaluates a patient with known or suspected heart disease. And guess what? The good news is, if we can take a careful history and perform a proper physical exam, we can determine more than 90% of what's wrong with our patient just by that alone. The trouble is, we're not doing it anymore. I have my residents years ago coming up to us to present a case. They'll give us the patient's chief complaint. What was the history of present illness? What were the physical findings? Not anymore. Now it's a patient in room 3042, and the CT scan shows. But I'll let you in on a little secret. There is not one fancy diagnostic test that has the sensitivity and specificity of a well-conducted history and physical. And for those people that are afraid of malpractice litigation, I sat as chair of the Florida Board of Medicine. The most common cause of a medical error today is failure to take an adequate history and physical exam, not even ordering the wrong test or the wrong side surgery. And I know, Jen, you're on the board as well.
I am.
The clinical method of evaluation that I was fortunate to have been trained by a legendary cardiologist and master clinician teacher named Proctor Harvey. His name, by the way, namesake is the Harvey mannequin, and many of you may have heard of the Harvey mannequin. It was named after Dr. Harvey. And Dr. Harvey preached a very basic, simple, hands-on, if you will, clinical method called the 5-finger approach, which includes a careful, detailed history, the physical exam, the electrocardiogram that Jennifer teaches so well, the chest x-ray, and appropriate selective utilization of laboratory tests. And if we take these 5 fingers and make a fist, we have the most powerful method to diagnose and treat a person with heart disease. But of all the 5 fingers, the most important one of all, the thumb, thumbs up. The history, just by talking to your patient, listening to your patient tell their story. The word story is part of history, isn't it? Understanding what the patient is telling you is the art of being a true clinician. And if you can do that, you can then really hone in on the 2nd finger, which is the physical exam, of what to look for. Because when we examine a patient, it is so important to be able to look for things before we actually even find them. It gets us back to the old adage in clinical medicine. You see only what you look for. You recognize only what you know. Even before that, Sir William Osler used to say, listen to your patient. He or she will tell you the diagnosis. The art of observation is very important. It reminds me of my very first day in medical school. I had a fancy professor stand in front of us in a graduated auditorium, and he showed us what he said was a urine specimen. He said this was a urine specimen of a patient with sugar diabetes. And he said he was going to pass the specimen to each and every one of us. And he wanted us to place our finger in the specimen and taste how sweet it is to make the diagnosis of sugar diabetes. We all cringed at the thought. We don't want to put our finger in there. After he passed around the specimen, which turned out, of course, to be apple juice, he smiled and said, if you had observed me closely, you would have realized that I dipped my fourth finger in the sample and I tasted my fifth. Oh, the art of observation. So remember, you see only what you look for. You recognize only what you know. Another common adage in medicine. Keep in mind that the most common conditions are the most common. The most common conditions are the most common. It's not that we won't see the rare ones. And I'm sure Jennifer's gone over many of the other STEMI mimickers and everything else rare. But we want to be able to make sure we recognize the most common ones. Leave the rare ones for television reruns on House MD. We don't want to miss the ones we'll see every day, right? After the history and the physical, the third finger, the electrocardiogram, what Jennifer teaches and preaches every day. Wonderful test, simple, easy to get a hold of, gives you a lot of useful information. Is your patient with chest discomfort in the throes of a STEMI, an ST elevation myocardial infarction, and door to balloon time needs to be rushed to the cath lab for a balloon and a stent within 90 minutes or 120 minutes, transferred to a PCI capable hospital? Did your patient with a cryptogenic stroke or TIA just have an embolism? Doesn't even realize he's an AFib? Or a syncopal episode and he's in complete heart block, needs a pacemaker? The fourth finger, the chest X-ray. Nobody looks at it anymore. We're lucky if we even look at the EMR for the report. We should get in the habit of looking at it though. There might be an interesting clue, you never know. The heart size could be large. Might be some heart failure going on. Calcification in a valve somewhere. Some clue that something is going on. And guess what? Purposely relegated to the pinky, the fifth finger, the smallest finger, are the myriad of elaborate and expensive, non-invasive and invasive laboratory tests and procedures. The cornucopia of tests that are literally available today at the push of a button in this technologically oriented society we all live in. But we need to order these tests selectively, appropriately, cost effectively. It should be emphasized that every patient does not need every test. Skillful use of low technology, high touch, the history, the physical, leads to intelligent, cost-effective use of high technology. Remember, hands before scans. Now, I'm sure most of you would agree that the need for this clinical, hands-on approach to medicine and nursing makes sense. But regrettably, the ability of today's practitioners to perform an adequate history and a skillful physical examination continues to diminish. Why? How can we explain this decline in clinical skills that are so important? Well, there are many reasons for this most unfortunate trend. Let me in on you on a few of them. To me, the most important, foremost among all of them, is the shortage of experienced master clinician teachers. The master clinician teachers of yesteryear, the Proctor Harveys of the world that I was so fortunate to have been trained by, have passed away. They're a vanishing breed, an extinguished species. Dr. Chizner is a hologram, I tell my students every day. I'm the youngest of the old generation and the oldest of the young. I always say there are 3 stages in life, Jennifer. There's youth, there's middle age, and there's you look good. I have entered the you look good stage. So we don't have the master clinician teachers, so no fault of anyone else. The art is not being passed along. Second reason, like a child that discards a favorite teddy bear for a new battery-operated toy that's got more glamour. Today's millennial continues to have such growing fascination and therefore reliance on technological advances to a fault. To reinforce this mindset is the volume-driven system of managed care that offers little or no financial reward for time spent talking to a patient or examining a patient. It's lopsided, it's totally upside down. In the RVU system at hospitals, we might get 0.13 RVUs for talking to a patient and examining a follow-up visit, but 15 RVUs for putting in a stent. Hello? Furthermore, we live in a litigious environment, don't we? That encourages the practice of defensive medicine, and therefore the ordering of many unnecessary, time-consuming, and potentially risky tests. Indeed, in this age of advanced technology, it is not at all uncommon for a patient to be put through an extensive battery of tests and procedures without a careful history or physical exam being performed at all, or even a stethoscope placed on a patient's chest. And as if that's not bad enough, what's worse today is what you are looking at right now, the computer. The computer has become the elephant in the room. Nowadays, the electronic medical record, the so-called I-patient, has become the focus of all of our attention. We are cutting and pasting all day long. But I say to all the medical students, when you had a personal statement why you chose medicine, and I said the same thing to the nurses and the nurse practitioners and PAs, not one of them wanted to bang on a keyboard. Nobody ever wanted to do that. That's not what we wanted. We wanted to take care of people. But today, the patient is no longer a real patient. They're the emoji for the eye patient. The computer is the focus of our attention. The computer is receiving wonderful care across the country. Unfortunately, the real patient's in the bed saying, where's my doctor? Where's my nurse? They feel neglected. When is my doctor going to come and see me, for God's sakes? Today, the doctor spends less than 10% of their time in direct contact with their patients. Less than 10%, and 5 times as much on the computer. And don't even get me why what happened since COVID-19, right?
Right.
Indeed, today's physicians spend much more time palpating a keyboard than a patient's chest, abdomen, or injured extremity. Despite its imperiled status and its crunch time for clinical cardiology and clinical medicine of all types, the time-honored art of cardiology and clinical cardiology and bedside medicine should not and must not become a lost art. I'm tired of the articles saying that the stethoscope has to rest in peace. No. For in spite of the current emphasis on technology, it is still true that most patients can be accurately diagnosed and treated by employing a clinical back to basics approach. So what I would love to do for the remaining time that I have this afternoon, I want to cover as much as I possibly can the basics of this lost art of clinical cardiology. And I want to demonstrate to each and every one of you how today's practitioner who relies on clinical examination skills with confidence can provide the highest quality of compassionate, state-of-the-art patient care. So let's get started, okay?
Okay.
What's the most common symptom by far that all of us talk about to diagnose someone with coronary heart disease? The two words, and they are chest pain. But I'll let you in on a little secret. The words chest pain, although the most common symptom to think about, are the most misunderstood words in the medical vocabulary of your patient. I will tell you from personal experience for decades, time and time again, the patient will go out of their way to deny the existence of those two words. There is something so deep-seated, even to deny it to themselves. They don't want to have a problem with their heart. They're afraid of dying. When they go to a cardiologist, it's not like going to an orthopod about their knee. They're afraid of dying. They're not just going to articulate that. And as Gregory House used to say, patients lie. They do lie. Let me give you a classic story, true story. All these stories I will tell you this afternoon are true. They're not inspired by a true story. They are true stories. This is a story about Rose. Rose comes to see us. I say to Rose, "What brought you here, Rose?" She comes with her granddaughter. Her chief complaint? "My granddaughter, she made me come and see you, Dr. Chizner." The grandma looks at her and says, Grandma, the granddaughter looks at her and says, "Grandma, tell Dr. Chizner what you're telling me you feel when we walk together at night." What does Rose say? "Oh, it's nothing. It's nothing." "What's nothing, Rose?" "Dr. Chizner, I'm 78. Aren't I entitled to feel out of shape? You know, maybe I get a little short of breath now and then, maybe I'm tired. But if I stop and rest, it goes away. I don't have any pain, Dr. Chizner." I said, "Oh, anything else with the shortness of breath?" And you know what Rose does? She goes like this, "Not really." If I wasn't looking at her, which most of us aren't, we're turned to our computer screen like this, or sometimes like this. She said no. We would have typed in "no chest pain." But what she really did is clenched her fist against her chest. The nonverbal clue, the pearl, the universal language of the hands, the classic Levine sign, named after the late Dr. Samuel A. Levine, Dr. Proctor Harvey's mentor. So the lineage continues. And oh, by the way, the original genetic lineage, Jennifer, was Sir William Osler, the father of bedside medicine. His disciple was the Boyd Dean at Harvard. After him was Samuel Levine. After him was Proctor Harvey. And Dr. Harvey's disciple is talking to all of you today.
That's right.
So you are now disciples of Sir William Osler. But now what Levine's sign was trying to non-verbally describe this constricting, tight feeling of the discomfort she's not going to tell me about, namely angina pectoris. Then she says, "Maybe I get a little fullness, Dr. Chizner. But you know, if I stop and rest, it goes away. Or if I belch, you know what? It's my acid reflux. My hiatal hernia is acting up again. I've had it for years, but when I take Tums or Rolaids, back to it, goes away. I said, really, Rose, how long would it last if you took your Tums or Rolaids? She says, gee, I don't know. I don't really pay attention to it. Well, is it seconds, Rose, minutes, hours? Oh, no, not that long, Dr. Chizner, maybe 10 minutes, 15 minutes. Oh, so now we're pulling it from her. We're extracting the data. But the Tums makes it go away. Rose, did you ever get caught without the Tums or Rolaids in your purse? Now she's looking at me like, I suppose so. Well, how long might it take for that feeling to last if you didn't have the Tums or Rolaids to take, Rose? Gee, I never stopped to think about it. I don't know. Maybe 10 minutes, 15 minutes, but it's not pain, Dr. Chizner. Okay, Rose, okay. Let me get it straight. Whatever this feeling is, and I know it's not pain, it lasts 10 or 15 minutes, and it lasts that long, regardless of whether you take Tums or Rolaids. So what makes you so sure the Rolaids or Tums relieve the feeling? And then like a deer in headlights, she looks at me with momentary introspection and says, gee, Dr. Chizner, you know, I never thought of it that way. But she just in her own way described classic exertional stable angina pectoris, but she didn't use the words. And 9 times out of 10, the patient will emphatically deny the existence of the words chest pain. And yet we say chest pain, the most common symptom of a person with coronary heart disease, don't we? In all my years of practice, and I'm not going to tell you how many there really are, but there's probably a couple on there now that know, I have yet to hear a patient tell me that they've had the most oppressive feeling in the retrosternal portion of their chest, going across the precordium, down the ulnar aspect of their left arm, accompanied by dyspnea, diaphoresis, and a feeling of impending doom. Not one person ever told me what Tinsley Harrison writes in Harrison's textbook of medicine. They don't read that book. They didn't even read Clinical Cardiology Made Ridiculously Simple. Some may describe the feeling as a tightness or a pressure, a heaviness, a squeezing, an aching, a burning, or indigestion feeling. Some may go to a dentist's office with a so-called toothache or jaw discomfort. TMJ is acting up. A woman might say, my bra feels just a little bit too tight when I window shop. Often women, vive la différence, have atypical symptoms, don't you?
Mm-hmm.
Abdominal, jaw, neck, back, shoulder pain, or just fatigue or shortness of breath, not even pain. These are the clues you have to elicit from the patient. Because if you stand there with a checklist or a questionnaire and say, do you have chest pain? The answer may be no. And then you move on and you miss the diagnosis of heart disease. Or the reverse may be true. The person can say they have chest pain, but it's not coronary disease. So let me give you some true examples about this. I was finishing a balloon and a stent in the cath lab. I'm not a Luddite. I do some high-tech stuff. And all of a sudden we get a call from our emergency room with the magic words that we get all day long. There's a patient in our ER with chest pain. And the software on the computer that Jennifer so well articulates every time says, with drama, 4 asterisks, STEMI, ST elevation MI with 4 more asterisks. That's the computer interpretation EKG. So the natural question is the cath lab ready? We got to rush it up. Time is muscle. 90-minute door to balloon time. We got to open up a plaque rupture clot with a balloon and a stent, don't we? Well, I'm finishing up. So I asked my absolutely wonderful nurse practitioner, Annie, who I've had the privilege of working for the last 18 years, to go down and see the patient while I'm finishing up. So Annie goes down and looks. And this is what she sees. She gets into the ER And where is the doctor? On the computer. That's where they are. He says to Annie, here's the computer readout. Patient's having a STEMI, needs to go to the cath lab. Your patient's in room 27. He says to Annie, but I haven't seen the patient yet. We're very busy. So what does Annie do? She goes see the patient. What does she see? She sees that the patient cannot lie down.
Oh, that's a clue.
She sees that the patient cannot breathe in properly. Yeah, it's a clue. What is it a clue to?
And the patient probably has no reciprocal depression anywhere on the EKG.
No. So what Jennifer is going to be alluding to, that Annie's now going to confirm, the pain is worse lying down, better sitting up, worse breathing in. So what does Annie do? She takes out this forgotten instrument called a stethoscope and decides to listen. So when she listens to the patient, I'll take it out of my ears for demonstration purposes. Instead of hearing lup, dup, lup, dup, she hears a 3-component pericardial friction rub of atrial contraction, ventricular contraction, ventricular relaxation. Annie diagnoses acute pericarditis. The computerized ECG reading was wrong. It didn't have the proper way of knowing that, as Jennifer just alluded to, there were no reciprocal changes. There was diffuse ST elevation and not even concave, not even convex, concave, the smiley face type. And there was some PR segment depression. Computer wasn't smart enough to see that. The patient did not need to be rushed unnecessarily to the cath lab at all. All the patient needed was anti-inflammatory medicine, NSAIDs and colchicine. And if this patient was in a rural hospital with no cath lab and was given thrombolytic therapy, they could have hemorrhaged to death with pericardial tamponade, and the death certificate would have read heart attack, death. That's it. But never had it. True story. I'll give you another true story. It is Palm Sunday at 4 o'clock in the morning. What are you guys doing at that time? I hope it's the same thing I am.
Sleeping.
Me too. All of a sudden, an emergency call comes in, though. Who's the patient? One of our own colleagues, the doctor. Oof. Dr. Chizner, hurry, it's so-and-so. He's having the worst chest pain suddenly out of nowhere. Now I'm getting nervous. So I rush to the hospital, right?
Mm-hmm.
But I'm thinking of what he looks like. He's a tall man.
Mm.
He's a slender, tall man with wide arm span, spider-like fingers, supple jointed. He played high school basketball. He looked like a person with a genetic condition we call Marfan syndrome. And they told me he came in with the worst pain he's ever had in his life. As I'm riding over, I'm getting really nervous because now I'm thinking, since we see only what we look for and we recognize only what we know, I was taught that Marfan's patients can get a dissection of the aortic, can't they?
Mm-hmm.
Now I'm worried about that. So I come into the ER, and this is what I see. He's really in pain. It's in his chest, straight through to his back. Bingo. The first EKG is in my hands, they show me, was normal. And ironically, it can be normal in something so severe and devastating. That's the irony. And the nurse tells me the blood pressure is 180 over 100. High. Okay. So I decide to listen to him with my stethoscope. And at first, when I listen, I hear lupped up, lupped up, lupped up. But then suddenly the music changes. And all of a sudden I hear lub, lub,
Ooh.
lub. I hear a blowing, high frequency, decrescendo murmur of aortic regurgitation, a new murmur of aortic regurgitation, a leaky aortic valve. And then I remembered a cardiac pearl that Dr. Harvey shared with me. A cardiac pearl is a fact or a finding that either leads to or makes the diagnosis of heart disease. Like a pearl, it does not lose its luster over time. It stands the test of time. The value will be today as it will be 50 years from now, as it was 50 years earlier. It will never change with the passage of time. Why? Because patients always present with the same symptoms and the same findings for the same reasons. We just have to bother, as William Osler said, listen to the patient. They will tell you the diagnosis and confirm it with the physical. So the pearl is now with this new murmur of aortic regurg in the chest pain to the back, hypertension, listen along the right sternal border. If it's louder, you've cinched the diagnosis. So I'm listening on the left sternal border and I'm listening to this. Lub, lub. Now I go to the right sternal border and I hear lub, lub, much louder. I turned to the nurse. I said, we have to get the OR right away. Time is of the essence. He might not even make it for the next hour. I don't even have time to worry about a CT scan, an MRI, a transesophageal echo, or an angiogram. While I'm preparing for this, the technician comes by for EKG number 2 as part of our chest pain protocol. Now the nurse takes a look at it, hands it to me and says, Dr. Chizner, the computer says this is a STEMI with 4 asterisks, ST elevation MI, 4 more. Remember, it was normal, the first one. So I look at it and guess what? It is a STEMI. There is ST elevation in lead 2, lead 3, and AVF. The nurse says, you want to go to the cath lab, right? I said, no, we need to go to the OR. She says, I don't understand. I said, the patient's having an inferior wall MI, yes, but not from traditional plaque rupture thrombus. The dissection is tearing the ostium and the right coronary with it. This is created by the dissection. We need to still go to the OR. And the patient went, had emergency life-saving surgery and lived for decades afterwards. True story.
There's a question that just came through. Is it louder on the right upper sternal border or the left? She was trying to clarify what you had said.
The classic interspaces to listen are the 3rd and 4th interspaces, because with normal aortic regurg, leaflet, it goes backwards to Erb's point, the left sternal border, 3rd and 4th interspace. Left, leaflet. With root, like the section, it goes to the right 3rd or 4th interspace, right root. So the key interspace to compare is not even the upper sternal border, it's the right 3rd and 4th compared to the left 3rd and 4th.
There was a celebrity, John Ritter, that had died of the aortic dissection. One of our members just mentioned, just to kind of bring this, round it out and bring it home.
Jenny, I used to mention that in all my speeches, that he was not diagnosed in the emergency room, and he could have been.
Yeah, sad.
Yeah. It's back to what you always preach. You don't want to hear that someone passed and you could have done something different about it, right? That's what drove your passion. I know.
Absolutely.
We're kindred spirits.
Yes, we are.
So you see the sounds, the murmurs that we can hear with the stethoscope, the so-called music of the heart, can provide valuable clues to the diagnosis. often without the need for more elaborate or expensive high-tech tests. The simple stethoscope, when used properly, can be an incredible clinical tool. Unfortunately, in this age of high technology, the stethoscope has rapidly become the forgotten instrument in medicine today. Oh, sure, we see it a lot. I see it worn draped across the neck of almost every doctor in the hallway. And some of the guys are really cool. They even go like that. I see it on television, on reruns of Grey's Anatomy, on House MD. I even had an air conditioning repairman walk around with a stethoscope. And he charged more than we did for a visit, just to listen to the duct. But today, most practitioners are not being trained any longer how to use it properly. And as a consequence, 90% or more of the most common conditions that could be and should be and used to be diagnosed no longer can be diagnosed. Sad but true. In the past, the stethoscope was considered the time-honored badge of the medical and nursing profession. And stethoscopic virtuosity was a sine qua non of a consummate clinician. But like everything else in life, times and fashions change. In the golden era of clinical medicine, a master clinician could look at a patient, examine a patient, listen to the patient, and make a diagnosis right away, and then apply the technology wisely. And they didn't even have the technology we have today, but they knew how to diagnose and treat the patient immediately. So the question that's begged by most people, they ask me, so Dr. Chizner, what constitutes a good stethoscope? So I look at the blogs back and forth, and I like to watch what people write. Someone writes, I like the red one. Someone else writes, I like the blue one. Someone else says, I like the gold laminated one. It really doesn't matter what color it is. So what's key? Well, a few things, really. I may be a little bit having inherent bias because this is what is called the Harvey stethoscope, named after Dr. Harvey, and he invented this triple-headed thread in 1962. But nevertheless, you don't have to have this one, but you really should have something similar in the following way. At the bottom of every good stethoscope should be a good diaphragm piece. The diaphragm, when pressed firmly against the skin, and I say the skin, not clothing, leaving an imprint, will accentuate high-frequency sounds and murmurs, like the murmur of aortic regurgitation. Lub, lub, or like the pericardial friction rub of pericarditis. Or a holosystolic murmur at the apex of mitral regurgitation that could travel to the axilla or the base of the lung. Or tricuspid regurgitation above the right ventricle, the lower left sternal border, that gets louder when you breathe in because more blood goes in the right side of your heart. The diaphragm piece. It should have a nice little bell. So when it's pressed gently at the apex, when you turn to the lateral position, accentuates low frequency sounds or murmurs. What's a low frequency sound? Could be a gallop of a heart that's weak, heart failure with reduced ejection fraction, F.A.C.C, systolic dysfunction. Lup-dup-dup, 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 lup-dup-dup. I don't think it sounds like Kentucky. Or it could be the S4 gallop with diastolic dysfunction, a stiff wall, F.A.C.P, heart failure with preserved ejection fraction. Or something we hardly ever hear anymore, unless it's an immigrant from Cambodia or somewhere else. Rheumatic fever causing rheumatic mitral stenosis. And then you get the rumble S1, S2 opening snap, rumble of mitral stenosis. Ruptable, ruptable, ruptable. But the bell is the one. Your stethoscope should have good tubing. Shouldn't be cracked so there are air leaks. In fact, I had that experience, Jen. I thought I was losing my hearing or I had wax in my ear. Turned out there was a slight little leak coming from below here. And once I realized that, it was all good again. It should be comfortable. The earpieces should be comfortable. It shouldn't be like you're having a laryngotomy and it hurts you. You have to be comfortable too. The patient, both of you have to have comfort. And most important, you have to have a method. The method that I was taught by Proctor Harvey is a basic method called the inching technique. It's very simple. So tonight, if you want to listen to yourself, you start at the right upper sternal border, second intercostal space, the so-called aortic area. And you listen there to lub and dub. Lub is created by closure of mitral tricuspid valve, dub by closure of aortic pulmonic. But dub is louder over the aortic area because that's where the aorta is. Systemic blood pressure, high, lub, dub, lub, dub. It's louder than the first sound. The second is louder. That's good to know because now you know where systole is, ventricular contraction, where it begins and ends between lub and dub. Anything after dub is in diastole during ventricular relaxation. So let's assume you were listening to yourself and you heard up here, lub, dub, lub, dub. Then you inched to the pulmonic area and heard normal splitting of aortic and pulmonic valve. Lub, dub, lub, dub, lub, dub, lub, dub, lub, dub. But then at the left sternal border, you heard lub, dub, lub, dub. You heard a murmur. It was in systole. It was short. It wasn't holosystolic. It was lub, dub. Phonetically, like lub and then H-U-H, dub, lub, dub. Say it. Say lub, dub.
Lub, dub.
That's the murmur. It's in systole. It's short. On a scale of 1 to 6, grade 2. There are 6 grades of murmurs. Harvey's grading. Grade 1 is so hard to hear. It requires special effort. The room has to be quiet, which is often difficult nowadays if it's an emergency room or a noisy critical care area. We used to say affectionately, it's the murmur only Dr. Harvey could hear. Now the students are saying it's the one Dr. Chizner could hear. The grade 2 murmur, faint, but you can hear it right away. Grade 3 is moderate, but once you can feel a murmur, it's with the palm of your hand, it's a grade 4. That's called a palpable thrill. If you take your hand and take your other hand, just tickle the hand like this. This is the part of the hand right by the metacarpals that is most sensitive. That's the part you'll feel the purr of a cat, the purr of a thrill. If you can feel the murmur, it's a grade 4. If you can take your stethoscope, still touching the chest, but partially lift it, it's a grade 5. And if you can see daylight between your stethoscope and the chest, it's a grade 6. So what in the world would a grade 6 sound be? A prosthetic mechanical valve, for example, which reminds me of a charming story, true story. Maria gets the first mechanical valve. She now takes a taxi cab in Washington, D.C. The cab driver is driving and hears the following. He doesn't have any idea where that sound's coming from. He stops the cab. He gets out of the cab, opens the hood, gets back in, starts the cab, and here's what he hears again. He turns around, he says, "Is that noise coming from you?" She says, "Oh, yes, that's my new heart valve." He says, "Doesn't that bother you?" She says, "No, it would bother me if I stopped hearing it." Another story Dr. Harvey once told me is one of the original guys who got a valve. He said, "It's good and bad. I play poker with my friends, and if I have a good hand, it gives it away." So getting back to the innocent murmur, if you listen to that lub dub and you have it and you're healthy, no symptoms, pulses are fine, neck veins are fine, precordial movements are fine, that's an innocent murmur as opposed to a guilty murmur. Innocent murmurs are very common. It's just normal blood flow through the outflow tract. If it's a child, it's usually the pulmonary outflow. If it's an older person, it's the aortic outflow tract. You do not have to get an echo to prove the diagnosis is correct. In fact, the echo will often give you a false diagnosis of heart disease. In the asymptomatic person with just an innocent murmur, the echo is so sensitive, the Doppler, it picks up physiologic leaks, say of the mitral valve or the tricuspid valve. It's called echocardiographogenic heart disease. It's a disease of the echo, not of the patient. That's the innocent murmur. So let's assume another person comes in. This person is now 50-some-odd-year-old man. He's walking, he gets tightness in his chest, short of breath, and a little dizzy. We think he might have coronary disease. But we listen, and in the aortic area, instead of lumped up, we hear dup, dup, dup. We hear a harsh, late peaking, crescendo, decrescendo murmur, like we're clearing the back of our throat. This harsh grunt travels into the neck, into the carotids. And as we inch to the apex, it becomes more musical. That's called Gallivardin's phenomenon. This person has severe aortic stenosis with exertional chest discomfort, exertional shortness of breath, exertional dizziness or syncope. They may even have a pulsus parvis et tardis, slow pulse, an S4, I don't think that sounds like Tennessee either, by the way. The electrocardiogram may also show left ventricular hypertrophy with strain. The chest x-ray may show calcium in the aortic valve. You haven't even ordered the echo yet, and you know what's wrong with your patient right away. The patient has severe aortic stenosis. We'll end up getting a TAVR or a SAVR, aortic valve replacement of some sort. But you knew it. You knew it. You weren't dependent, beholden to the machine to tell you. A young girl came in to see us, very anxious young girl. She's having all kinds of chest pain and palpitations, very nervous. So when you listen to her, lup, dup, all of a sudden in the mid-sternum, lup, dub, lup, dub, there's a sound in mid-systole, lup, dub. That's a mid-systolic click of mitral valve prolapse. You might hear two clicks, lup, dub, lup, dub. You might hear a series of clicks like a deck of cards, lup, dub, lup, dub. You might have a click murmur, lup, lup, mid to late systolic murmur, or a click whoop, lup, whoop, like whooping cough, or a honk like a goose, lup, honk, lup, honk. This is the music, the classic auscultatory findings of mitral valve prolapse. So let me tell you a true story about Lisa. Lisa's 26 years of age. She comes to see me with her mom. She's the last appointment of the day on Thursday. She's seen several other doctors. In fact, she's scheduled for the next morning to have open heart surgery to repair a very seriously leaking mitral valve. I look at her, she looks fine. So I said, okay, tell me why we're here, Lise. Do you have any symptoms? She said, yeah, I get chest pain. I get short of breath and my heart races at times. She hit the trifecta. She has all three classic symptoms from Heartland, doesn't she? So let's do a little deeper dive. Lisa, tell me about the chest pain you're having. She says, well, Dr. Chizner, here it is. It's right there. And if I turn like that, it hurts. Is that coming from her heart? I didn't think so either. So sounded good. We're going to discard it. We're down to 2 symptoms. Let's talk about her shortness of breath. Lisa, tell me how short your breath you are. Tell me what that means. She says, well, it doesn't want to go all the way down when I take a deep breath. Lisa, do you exercise? Sure, I do cardio. I do Stairmaster, rollerblade, whatever. I said, do you huff and puff with that activity? No. So her breathing is not organic heart or lung disease. So we're going to move that off the table. We'll get back to the palpitation in a moment. So I decided to do something very novel. I take out a stethoscope to listen to her. And as I inch my stethoscope, looked up, looked up, looked up. At the left sternal border and apex, I hear look, look. I hear the mid-systolic click and the mid to late systolic murmur of mitral regurgitation from mitral valve prolapse. But I know this is not severe mitral regurgitation. How do I know? Well, to be severe, the mitral valve has to start leaking as soon as the heart squeezes, therefore holosystolic. And all that volume that goes back has to go back with full force in diastole. And it creates an S3 with a lot of after vibrations called a flow rumble. So there's a holosystolic murmur and an S3 with a flow rumble in diastole. That is truly clinically severe mitral regurg. She didn't have that. She had nothing in diastole. It was clean. And in fact, the whole murmur wasn't even holosystolic. It was mid to late. So I knew it wasn't severe. I looked at her and her mom. I said, so why did all these other doctors, each one of them, everyone said she needed the surgery, by the way. And the answer out of the purse comes not only the echo she had, but the fancy transesophageal echo she had. They even put her to sleep and put a tube down her throat into the esophagus to look up close and personal at that mitral valve. But when you see mitral regurg on Doppler echo, I'll let you in on a secret. You're not seeing volume. You're seeing velocity. There's a difference. The color is exciting. It's a wow factor. It's like Jenny loves to paint. It's art. But velocity is not volume. It's not the same as putting dye in a cath lab into a ventricle, watching it go to the atrium. It's velocity, not volume. So the echo report, like the EKG report for the previous cases, was overstating the case. It wasn't severe. But since everyone relied on the almighty test saying severe MR, they went along for the ride to repair it. And one person said, don't worry, Lise, we won't have to crack your chest. We can only make a 6-inch incision under your left breast, as if that was a consolation prize. Lisa never needed the surgery. This story took place more than 20 years ago. Lisa was going through a divorce.
Mm-hmm.
That's why she was having the autonomic breathing, the deep sigh, the chest pain. And as far as her racing heartbeat, I'll give her a very common arrhythmia Jenny talks about all the time. I'll give her AV nodal reentrant tachycardia, SVT. She has that. And we were able to teach her not to even have to come into an ER for adenosine. We can break it with something simple called a vagal maneuver. We can take a deep breath, we can bear down, or we can touch the carotid, which reminds me of a very charming story Proctor Harvey once told me. And the story was about Dr. Levine. This was before all of us were born. Dr. Levine was chief of cardiology at Boston at the Brigham Hospital, and he was called to the emergency room on a Saturday night to see a young nurse. with tachycardia. Heart rate was 180 to 200. All attempts to break the tachycardia were unsuccessful for whatever they tried back then. They probably had a very early form of digitalis called cetylanide, wabane, something silly like that. They had no adenosine back then. So they called Dr. Levine because they couldn't help the young nurse. So he comes in with plans of attending an opera. It's a Saturday night, mind you. He comes in dressed in a tuxedo, which at that time meant a top hat, white gloves, tails, and he was sporting a cane. Dr. Levine walks into the emergency department at the Brigham. He looks at the young nurse. He looks at the monitor. He lifts up her chin, takes his 2 fingers, finds the sweet spot of the carotid massage, and voila, she goes back into sinus rhythm. He leaves the exit and goes to the opera. She brings her family to the bedside and says, "You're not going to believe what just happened. I had all these doctors, nurses, interns, residents. No one could help me. So in desperation, they had to call in a magician. And he solved my problem immediately." True story. I'll tell you another true story. This is a 25-year-old guy trying out for sports. He was going down the football field and he fainted. So what do you think about? Because you see only what you look for, you recognize only what you know. The most common cause of sudden death in an athlete is hypertrophic, exactly, HOCM, hypertrophic obstructive cardiomyopathy. So I'll let you in on a cardiac pearl of how to diagnose it. You shake hands with the young man, and it's good to shake hands. It creates that bond, that trust, that confidence, the clinician-patient relationship. But it's a trick, it's a magic trick. You shake hands, and then you feel the radial pulse. And instead of a normal rate of rise, it's a quick flip, like if you took your finger and hit your finger, flip, flip, flip. Quick rise pulse, number 1. You're thinking of the most common cause of a quick rise pulse, which is aortic regurgitation, like a water hammer pulse. So you're going to listen for that blowing decrescendo diastolic murmur of aortic regurgitation. Lub, lub. You do not hear it. Instead, number 3, you hear a systolic murmur at the left sternal border, not the upper, not into the neck. It's a crescendo, decrescendo, like the lub, dub. You hear that murmur. So the next thing you should do is a squatting maneuver. You should squat the athlete, and the murmur gets faint, and stand the athlete, and it gets loud. That's called the 1, 2, 3, 4 diagnosis of hypertrophic obstructive cardiomyopathy. I'll repeat it. Number 1, quick rise pulse. Number 2, listen for aortic regurgitation, but it's not there. Instead, number 3, systolic murmur at the left sternal border. Now you do the squat and the stand, and the murmur gets faint with squat, gets loud with stand. You've made the diagnosis. Another person comes in, common symptom, very common symptom, shortness of breath. Common for heart disease, common for lung disease. How do you tell the difference between the two? Nowadays, the usual answer I get in a classroom is check the BNP, the blood test. Well, it is the most sensitive test, but I think it might be wise just to take a history from the patient. You might discover the patient can't lie flat, has to sleep up on 2 or 3 pillows at night, has orthopnea, may even get up in the middle of the night gasping for breath, has PND, paroxysmal nocturnal dyspnea. And then if you shake hands with that patient, you might feel a characteristic change in the arterial pulse. Strong, alternating with weak, strong, weak, strong, weak, strong, weak. That's called pulsus alternans. That's a clue to heart failure with reduced ejection fraction. So when you're going to listen for the classic S3 gallop. With mitral regurg murmur, likely. You've made the diagnosis of heart failure. It is a clinical diagnosis. Because you can have heart failure with preserved ejection fraction, with reduced ejection fraction. You can have someone whose ejection fraction stays 30 and they're not in heart failure. They're compensated, they're treated. They're on all the appropriate treatment. They're on the ARNI or the ACE inhibitor or the ARB. They're on the carvedilol or the topilosuccinate or the mineralocorticoid antagonist, the plerinone, and nowadays SGLT2 inhibitors, whatever. But they're not in heart failure. It's just an ejection fraction. It's a number. I remember I was walking down the halls at the hospital and one of the PAs came over to me and said, Dr. Chizner, would you see my mom? I said, I'd be honored to see your mom. What's the matter? So the mom comes in. The mom is 70 years of age. She's from Jamaica. She had over 20 doctors since she has been sick, and they're labeling her with heart failure. She comes into the office with 4 echoes that she's had and 2 heart caths. That's pretty high tech. But no one can tell her why she's in heart failure. Oof, what a challenge for Dr. Chizner. How in the world am I going to do this if 4 echoes can't and 2 heart caths can't? What do I know that they don't, right? Well, may as well try. So I shake hands with her, and guess what I feel? I was expecting to feel pulses alternate, strong, weak, strong, weak. It wasn't there. Instead, I felt a quick rise pulse, quick, quick, quick. So I remembered the pearl Dr. Harvey shared with me that there are 4 things basically that cause a quick rise pulse. The first one that's most common we've been over, aortic regurgitation. So if she had it, it would be a diastolic blowing murmur. But I knew she couldn't have that. Why? The 4 echoes won't miss that. The 2 heart caths won't miss that, so it can't be that one. We're down to 3 possibilities. What's the second one? We just went over it. Hokum. I'd listen for the systolic murmur and see if she could squat or stand to get faint and loud, but I knew she couldn't have that. Why? Echoes are not going to miss it. Cath's not going to miss it. Can't be that one. What's the third one? Severe mitral regurg. When you have a severe leak, it goes forward and backward and meets no resistance, so it hits the artery with a quick rise, like a mini water hammer pulse. Severe MR can give you a hyperkinetic quick rise pulse. You would listen for the holosystolic murmur at the apex, but she's not going to have that. Clearly, the echoes won't miss it. If anything, it'll overdiagnose it. The caths won't miss it, so she couldn't have that. We're down to one other possibility. And I said to myself, wait a minute, she's 70 years of age. If she has this one I'm thinking of, it meant she was born with it. OMG. I said, I can't believe this, but may as well go through the ritual, right? So I'm listening at the aortic area, lup-dup, lup-dup. Now I get to the pulmonic area and the music changes. This is exactly what I heard. I heard a continuous machinery murmur. I said, OMG. I said to the daughter, the PA, listen to mom over here. She's listening. She goes, wow, what is that, Dr. Chizner? I said, what do the 4 echoes tell you it is? Nothing. What do the 2 caths tell you it is? Nothing. I said to my wonderful nurse practitioner, Annie, take a listen up here. She says, what is that, Dr. Chizner? I said, that is something she's born with. It's a patent ductus arteriosus since birth. And all we had to do was send her to a baby doctor and percutaneously close it, and she's been fine ever since. True story, Jen.
That's awesome.
I could tell you so many stories. We're getting a little late, so what I think I'm going to do is share with you now the most dramatic story of my entire professional life. May I do that?
Please.
So I just arrived in Fort Lauderdale about 6 months after training with Dr. Harvey. And one of my colleagues, a heart surgeon, comes up to me and says, Mike, a friend of mine in church, a nurse, her mom is 51 years of age, and she's up at another hospital up the road. She's had all the tests you could possibly think of, and they told her that she has an end-stage cardiomyopathy, a very weak heart, and that there was nothing that they could do for her anymore. They actually told her to get her affairs in order and that she only has 2 or 3 days left to live. Then he loads the following bomb on me. I'd like to transfer her here to you, Mike. I'd feel more comfortable if you listened to her with a stethoscope. I see what you're doing. I would just feel better if you did. When I listened to this story, I told him, well, I'm very flattered and honored that you feel so much about this, but it's highly unlikely I'll give you any new medical input or advice. But if you want to transfer her for emotional support, compassion, and care, I'll be happy to help you. He says, thanks, I really would appreciate that, Mike. So they transfer her. It was a Tuesday at 2:30 in the afternoon, and I remember it so vividly like it was yesterday. She comes in on a stretcher, Jen. She looks so sick. She was cachectic, no muscle mass, wasted. But her belly was so protuberant with fluid, ascites. She looked like this kwashiorkor baby with ascites. And the neck veins were so distended, they were standing up like a rope with a tension all the way up to the earlobes. I said, oh my God, how am I going to help this poor woman? And as I have her rolled in, I shake her hand, which is the magic trick, the connection, the bond, and I'm feeling the radial pulse. I'm purposely trying to feel for pulses alternans. And I say to her, I'm Dr. Chizner, I'm so sorry, you're not feeling well. Her name was Rosemary. And as I'm feeling her pulse, I don't feel pulses alternans. I'm surprised. If she's going to have that much severe heart failure, I'd expect it to be there. I said, maybe my fingers aren't sensitive enough. I'm just out of training. I got a long road to go to even come close to having my skills perfected. But let me listen. I enjoy music. I was trained in music. I played guitar and piano, and I was trained by Dr. Harvey, who was my Chopin, my Beethoven. And he taught me what to listen for, right? I'm going to listen for the classic signs and symptoms of heart failure. I'm going to listen for that S3 gallop. If you have a cardiomyopathy and heart failure, you can have leaky valves. I'm going to listen for mitral regurg, that holosystolic murmur at the apex that travels. I'm even going to listen over the left sternal border for tricuspid regurg, holosystolic, that gets louder when you breathe in. She had none of it. Ooh. I was taken aback. I said, what in the world? I said, let me listen to anything I could hear. And I start inching, and all I heard was one extra sound after dub. I heard lup-dub, lup-dub-dub, lup-dub-dub, lup-dub-dub. One sound. I said, what in the world is that sound? Is it an opening snap of mitral stenosis? Did I miss a rumble? Lup-dub-brr, rup-dub-brr. No, it wasn't there. All she had was lup-dub-dub, lup-dub-dub, that extra sound. And then the light bulb goes off in my brain. I remembered a cardiac pearl Dr. Harvey shared with me. And his typical Southern drawl from Lynchburg, Virginia, God bless his soul. He said, Mike, anytime you see what's heart failure, but you don't hear what you're expecting, and you hear that extra sound and you see those neck veins, that sound could be a pericardial knock sound. And those neck veins and that sound is a clue to a rare condition called constrictive pericarditis. That's why you're not hearing the S3. That's why she doesn't have the leaky heart valves. That's why she doesn't have any of the sounds, murmurs, or alternans you're expecting to pick up. So then I remembered that with constriction, you can get calcification in the pericardium. On her stretcher was a manila envelope in those days with the x-ray in it. So I take the x-ray out and I'm looking under the light and I'm trying to see if there's any calcium in the pericardium. And lo and behold, it wasn't there. Then I looked it up. 30% is there, 70% don't get it. I said, oh no, I have nothing else to go on except the sound and the neck pain. And I turn to the surgeon and I say to him, I cannot promise you anything, but it's possible she has constrictive pericarditis. And if she does, if we take her to surgery and remove the pericardium, we could possibly help her. And now he's stunned because now I dropped the bomb back on him. He realized what I just said. He said, but Mike, if I take her to surgery, she may not survive. I said, I understand. But if we don't try, she's not going to have much longer to live. So we decided to speak to the daughter, who was his best friend from church. She's a nurse, and her two sisters and the patient. We all spoke and everyone agreed to take a chance and go to surgery. I accompanied them. We were there for 14 hours in the operating room, literally scraping the pericardium like it was an orange peel, a cast firmly matted to the heart like a straitjacket. That's why she had all the fluid buildup. Her heart couldn't function properly. Once the pericardium was removed, everything went back to normal. She walked out of the hospital a few weeks later, a new, well woman. The story gets even better. A year and a half goes by. She comes back in the hospital with abdominal complaints, diarrhea, malabsorption. And we in those days do a house MD workup. We biopsy her intestine. It's PAS positive macrophages, whatever the heck that is. And we give her a diagnosis of Whipple's disease. WTF, Whipple's disease. I said, I wonder if she had this all along. I wonder if constrictive pericarditis is even associated with Whipple's disease. What did I know? I looked it up back then. There was not even one case report. Today, yes, it's associated. Back then, we didn't even know it was caused by a microorganism. Yes, now we know, but not then. So I called the pathologist at the hospital. I said, did you save the pericardial tissue from a year and a half ago? He says, yeah, Mike, why? I said, can you put that stain on it and just let me know if it's positive? He calls me in the afternoon. He says, it's positive. So all along, she had this rare condition, Whipple's disease, causing the rare complication of constrictive pericarditis. But you know, every time I would give a lecture to medical students, to doctors, nurses, nurse practitioners, PAs, or even the public, I would purposely close with this story, not only to emphasize how clinical skills in a stethoscope can make a diagnosis, but in this case was able to save a life when the so-called cutting edge technology of the time didn't quite cut it. After telling this story for 25 years, I suddenly, out of nowhere, received a letter on my desk. It read like this: Dear Dr. Chizner, it's been a very long time since you've heard from me. In fact, it'll be 25 years this November. She said, you were just a young boy starting your career, but with determination and perseverance, compassion and care, you and your colleagues diagnosed my problem and saved my life. I've seen 3 beautiful daughters grow into lovely young women. I have 4 beautiful grandchildren. I am now 75 years of age. I want to thank you for my life. Wow. I was so moved, I cried. When I called her on the phone, Jen, I said, where have you been for the past 25 years? She said, well, I've been just fine, and I haven't had to see anyone all this time. Soon thereafter, they asked me to give a keynote speech to the American Heart Association Go Red for women.
Mm-hmm.
And could I present a woman with heart disease? I knew exactly what I needed to do. I called Rosemary on the phone. I said, would you honor us, you and your daughters, as my guest? I want you to sit at our table and I want to tell all these women our story. She said, yes. I said, but let's do some drama together. Let me tell it before they even see you. I'm going to sequester you outside, and then I want you to walk in. And that's what happened. I tell the story to 500 women dressed in red, and the mascara is dripping down their cheek with this story. And then all of a sudden, the door opens up in the back, and in comes Rosemary, white slacks, red top. She hugs me and says, oh, I just love this little boy. I was no little boy, but in her mind. And then she embarrasses me completely. She says to everyone, please learn how to use a stethoscope. She said, I was a poor woman struggling to make ends meet. I was paying off 28 doctors with bills $5 a month. They told me I only had 2 or 3 days left to live. And I was transferred, and Dr. Chizner puts a stethoscope on my chest, and I am in front of you today. It's pretty embarrassing. Then she turns to me and says, do you remember what you wrote on the top of your bill? I honestly did not remember back then. She looks at me, she says, you wrote, consider this bill paid in full. I just broke down. And I realized what it takes and means to be a doctor. We all had a personal reason we went into healthcare, didn't we?
Mm-hmm.
I hope that my talk this afternoon inspires everyone. I hope it inspires you to pick up a stethoscope, to practice your techniques, perfect your clinical history and physical examination skills, and rediscover the lost art of clinical cardiology and medicine. The rewards of rediscovering this lost art are many. In particular, a feeling of great satisfaction in arriving at a rapid, accurate, and cost-effective cardiac diagnosis using your own wits and senses, what we in the medical profession refer to as the fun of medicine. In addition, you'll be establishing a personal bond with your patient, the so-called laying on of hands, which will help foster the close rapport, the trust, and the confidence so important to the privileged doctor or nurse patient relationship. For as it is said, no one cares how much you know until they know how much you care.
One of my favorite all-time quotes. Of course, that's what you end with.
I want everyone to remember, and this will relate to you even more, Jen, as we continue to move into the 21st century, a time when the American healthcare system has undergone unprecedented change. The one constant above all else is the vital importance of the doctor or nurse patient relationship. To me, being a good doctor, it takes knowledge and skill for sure, but it takes much more than that. More importantly, it takes honesty, integrity, a selfless concern for humanity, a deep sensitivity and compassion for the suffering, touched with a good, strong dose of optimism, humor, and wit. I have always felt, and I feel even stronger today, as ever before, it is as important to heal the mind as it is to heal the body. For when the body is ailing, the mind is ailing as well, and it needs that comfort and attention too. So I leave you all today with the credo of the caring bedside practitioner. Cure if you can. Alleviate if you cannot. but always comfort and support. And never, ever take away hope. Thank you for your time, your attention, and for allowing me to present my thoughts on a subject matter that is near and dear to my heart. God bless each and every one of you.